I'll assume so. I'm just gonna stop my video just to make sure that I preserve bandwidth since I'm remotely. I apologize I cannot be there in person, but I certainly appreciate Niraj, your kind invitation to join you guys today. I'll be talking a little bit about multimodal monitoring neurocritical care, in particular, how we approach it here at the Cleveland Clinic. I'll start by saying that I don't have any relevant financial disclosures associated with this talk. I will mention a number of medical devices and technologies that we utilize, most of which have FDA approval for the indication, but in case I don't, in case I speak about any technology that doesn't have any FDA approval, I will make sure to point that out, of course. Old slide, as you know, whenever we think or talk about brain injuries, you have the primary sort of brain injury that takes place, whether it is an ICH, subarachnoid, or TBI, etc. And but however, in the hours and days following that primary injury, of course, there is a number of potential injurious mechanisms that take place, or secondary injuries. And these are the injuries that we as neurointensivists are trying to minimize or trying to placate as much as we can. Some of these injuries can be predictable, and others are a little bit more difficult to predict. And they can come in various flavors, right? So it could be ICP elevation because of cerebral edema, it could be hypoxia, some ischemic component, fevers, infections, alterations in the internal milieu in terms of glucose, sodium alterations, etc. So as I mentioned, some of these are predictable and others are not. And the less predictable they become, the more impact that neuromonitoring could potentially have in preventing them and modifying their course. Now, for years, if you look at your any ICU, any neuro ICU room, you have your bedside monitor, and primarily the focus there is on cardiopulmonary function, right? You get your EKG tracing, you get your SATs, your blood pressure, of course, and the one sort of neuro item that you get is intracranial pressure, and that's that, right? That's it. You don't get much else. But there is a wealth of data that we can now obtain that would be quite helpful. I would like to be able to have display in that or some sort of monitor. Cerebral metabolic rate of oxygen, intracranial pressure, cerebral oxygen delivery, cerebral blood flow, any sort of electrical dysfunction, cerebral autoregulation, just to name a few. Now, here in the US, we have primarily one platform which does have FDA approval for multimodality monitoring. Is the Moberg here in the right upper hand corner. And it does sort of connect to the bedside monitor and can display a lot of the data. It also connects to a myriad of devices, TTM devices, pupillometers, Bowman for cerebral blood flow, et cetera, Lycox for cerebral oximetry. There is another platform called ICM Plus, which actually is really a research platform, doesn't have FDA approval, so that distinction needs to be made. But actually, it's my preferred. We have both here at the clinic. I prefer ICM Plus because of the flexibility in terms of doing manipulating the data and doing sort of different types of research. They both try to do at some level the same thing, but at another level are quite different. And I'll elaborate or show a few real life examples in a little bit. Now, when we look at or talk about multimodality monitoring, it can come in different flavors, right? And some of the questions that one has to answer is, do we want invasive or non-invasive monitoring? Do we want continuous monitoring, ideally, or episodic, such as even a CAT scan, right? One of the great potentials, at least, of this type of monitoring is that you could hopefully individualize the approach to care. But as Dr. Freeman mentioned before in his AI machine learning talk, you could easily end up with data overload. Just to give you an example, ICM Plus samples data 300 times per second. So depending on how long you monitor a patient for, some of the recordings that we have, we end up with millions and millions of data points. It's difficult for the human mind to analyze that, right? And really, and I think he made a plea for this, we need to get more trained in bioinformatics and understanding machine learning and AI, to be able to effectively use all this data and try to positively impact patient outcomes. And as I mentioned before, there is a wealth of different devices. And there is actually some guidelines put forth by the Neurocritical Care Society. There was a consensus conference on recommendations for multimodality monitoring. I think even though a lot of them have strong recommendations, the quality of the evidence, as you can see, for the most part, is actually quite weak. As I mentioned, there are different probes that we can use. Some of them are invasive, as depicted there, and they range from EEG leads that go sort of on the surface and the cortical aspect of the brain, quite popular for the detection of CSD, or cortical spreading depolarization, which is sort of a hot topic in subarachnoid hemorrhage. And now, for quite a few years, we've been using cerebral oximetry probes that are invasive, as well as cerebral microdialysis probes. They both have pros and cons, if you will. But there was last year this paper that was published on patients with subarachnoid hemorrhage, looking at was a small meta-analysis looking at the literature on different approaches for multimodality monitoring, showing that on top of the standard management, if we added one of these three modalities, and most of them, to be fair, included either oximetry or microdialysis, but if the management includes one of these modalities, the outcomes of the patients actually seem to be better. So making well, not a randomized controlled study, of course, making an argument for this type of monitoring, at least in subarachnoid hemorrhage patients. Now, in our ICU, we have taken a little bit of a different approach. Instead of going for invasive probes, we actually want to do exactly the opposite. We're doing all non-invasive monitoring devices, which I'll share with you in a minute, for a number of reasons. One, because then we can capture anybody we want, or almost anybody we want. We're not depending on the surgeons to come and do a burr hole and place some of these devices. And of course, they are reluctant because the potential risks of placing invasive probes in someone's brain. So I'm going to take a little bit of I'm going to deviate a little bit from monitoring and talk about cerebral autoregulation, just because a lot of aspects that I'm going to discuss next, it will be helpful to have a sort of a brief working knowledge of what I mean when I'm talking about cerebral autoregulation. Everyone in med school remembers the Lassens curve, sort of that ability to maintain blood flow more or less constant regardless of changes in blood pressure. Turns out that in reality it's a little bit more complex than that. I think is, from a theoretical standpoint, is perhaps helpful to visualize it that way, but we know that in reality it doesn't quite work that way. But at the most basic level, if your blood pressure drops, obviously your cerebral blood vessels vasodilate to try to keep up with cerebral blood flow. Conversely, if your blood pressure increases, your vessels constrict and try to minimize the flow so that you don't have major alterations in autoregulation. Now, it turns out that a lot of patients with brain injuries have impaired autoregulation, and that could potentially be a basis for that secondary injury that I was referring to earlier. We also know that autoregulation doesn't really fix quick changes in blood pressure, and I think that's an important point. We're talking about sort of a slow fluctuations in cerebral blood flow, or blood pressure rather, that can be sort of addressed with autoregulation. The easiest example is the one you have there on your bottom right. Most of you are sitting down, I presume. If you were to quickly stand up and we were measuring your CBF, and presumably all of you are normal, with normal intact autoregulation, you would still have a drop on your blood flow of some degree. And what autoregulation is going to accomplish over time is try to restore that balance. But that's going to take a little bit of time. It's not something that happens right away. Also, in terms of the different technologies we have to assess autoregulation, ICP, invasive ICP waveform, by far is the most common technology utilized, but certainly not the only one. One can use transcranial Doppler ultrasound, near-infrared cerebral oximetry, which is non-invasive, of course, as well as, it turns out, as I'll show you later, non-invasive ICP devices. The other deviation I'm gonna take in my talk today is talk about blood pressure control in ICH. And I have to say, when I realized after the kind invitation by Dr. Naval that I wasn't going to be able to be there in person, I actually was quite disappointed for a number of reasons. including the fact that knowing that Santosh was going to be there and his interest in ICH research, I really wanted to have this discussion with him in person. But through the magic of data massaging, right, we started with 2 negative studies on blood pressure control in ICH, INTERACT-2 and ATTACK-2. As the authors themselves recognized their primary endpoint was negative. And somehow, as I said, with a little bit of data manipulation, we end up with positive data. And if you look at the most recent recommendations for the management of blood pressure in ICH in 2022, they give you a target, to 140, keep it between 130 and 150. Again, based completely on 2 negative studies and a lot of post-hoc analysis, which is sort of another fancy word for massage. Interestingly, though, the whole concept of blood pressure control after ICH, at least the theory has for the longest time been that you're preventing hematoma expansion by controlling blood pressure, and therefore that explains the improvement in outcomes. Well, it turns out, and this is from the famous editorial after INTERACT-2, they acknowledge the reasons behind this trend, remains a mystery, and remains a mystery because there was no such reduction in hematoma expansion in this patient population. So, and if you look more closely at the strength of the recommendation for blood pressure control, it's actually quite weak. I don't know, Dr. Naval perhaps has the fragility index for that particular studies. I'm going to venture here that it's pretty low. But even the recommendation, the American Heart Association had to soften it quite a bit, and very close to class 3, to be honest with you, which personally I think is where that recommendation belongs. So how are we approaching that here, leveraging our multimodal monitoring program and some of the tools that we have? So we use a lot of near-infrared oximetry, as I mentioned before. It's a couple of stickers that go in the forehead. They measure relative percent of oxyhemoglobin, and all things being stable and equal, in particular the FiO2, is a surrogate marker for cerebral blood flow. So an actual patient of ours came with that ICH depicted there. We monitored that patient for a number of hours, and you have sort of a graphic summary of what autoregulation looked like for that patient. Green, of course, being normal autoregulation, and red being quite abnormal. And as you can see, there are big chunks of time where the autoregulation in this particular patient was quite abnormal. Now, what the way autoregulation works or is calculated, the dynamic autoregulation, is based on a Pearson correlation. So +1 is as impaired as it can be, -1 is completely normal and intact autoregulation. The question is, where do you draw the line? So we did this last year, about 20 patients that we monitored when we decided to just stop and analyze our own internal data, and use different, as you can see in table 3 there, different thresholds, try to find out what the right threshold was. And it seems that 0.3 it has the best predictive value for in-hospital mortality. Now, small numbers, obviously, but the important thing is that if you look at other studies in stroke, ischemic stroke, and TBI, that threshold of 0.3 keeps coming back. We didn't want to assume that that was the right thing to do, so we wanted to go back and analyze different thresholds. But that sort of re-emphasizes that seems to be quite relevant. And as you can see, patients that spend the percent of the time that they spend over that autoregulation index of 0.3, remember, higher is abnormal, lower is normal, actually correlated quite well with mortality. Now, as I said, small numbers. And besides the small numbers, obviously, doesn't necessarily mean causation. It could be that the injury is so severe, and that's why the autoregulation is impaired, as opposed to the impaired autoregulation leading to secondary injury. So we acknowledge that. However, our hypothesis and the way we're moving forward with our patient population is using autoregulation guided, personalized, optimal blood pressure in ICH. What do I mean by that? We looked at the blood pressure at which, or the mean arterial pressure at which the index of autoregulation is the lowest, as you can see in this parabolic black curve over there. And that to us indicates that that's the blood pressure range where autoregulation is the best and the brain is the happiest, if you will. But also it allows us to calculate, at least theoretically, the upper and lower limits of autoregulation, meaning As your blood pressure decreases, your autoregulation index goes up, and once it crosses that magic threshold of 0.3, as you see here on the left, you potentially are risking hypoperfusion, and you increase the risk of ischemic stroke. As you know, depending on which series you look at, 25 to 40% of patients with ICH can actually have ischemic strokes. And we think that one of the variables that contributes to that, besides the presence of a vasculopathy, is the fact that they may be hypoperfused. And you're doing that because you're going blind by what the American Heart Association is telling you in terms of blood pressure range of 130 to 150, which may or may not be right for you, particularly if you live in the 220s and your autoregulation curve is shifting. On the other hand, the percent of the time that you spend above the upper limit of autoregulation, we hypothesize, actually can increase your risk of hematoma expansion. Something that they failed to demonstrate either ATTACK-2 or INTERACT-2 with this one-size-fits-all approach, but we're theorizing and we're actively looking at. So this is, I should mention, this project is has been done primarily by one of our fellows, Katie Hassett, who now joined us and is doing a master's in clinical research, and this is sort of her project. So we're hoping to get closer to 10 patients and reanalyze, 100 patients and reanalyze our data. But it's not just hemorrhage or ICH. We also utilize some of this technology for our ischemic stroke patients. So you can see here an 82-year-old woman with various vascular risk factors had a common carotid occlusion with fluctuating exam. By the time she came to us, her NIH stroke was 4. So at the bedside with interventionalists, there was no plan to go after this because she really had minor symptoms. All of a sudden, as we're talking about what to do for the night in case anything happens, right there, her exam worsens, her NIH increases to 20, so she quickly goes for stenting. So they're able to stent the common carotid, that recanalize, and everyone is happy. Again, I connect her to our near-infrared. And post hoc, when we analyze the data, as I said, we don't use this yet because it's not FDA approved to make any changes unless patients are part of a clinical study of a trial. We realized that for a period of time, as you can see, her optimal mean arterial pressure predicted was around 76 millimeters of mercury. But for a period of time, though, we actually were above the upper limit of autoregulation. You can see that early on, there is a lot of red, and as time goes by, that red becomes less and less prevalent, and we see a little bit more green, and we know that autoregulation improves over time. Unfortunately, she did develop a little bit of hyperperfusion syndrome, have some degree of cerebral edema and a headache, and we think that was related to having blood pressure goals that were within the parameters that the endovascular team wanted, but evidently for her, because she tends to run a little bit lower, were a little too high. So this is potentially another use for this sort of multimodality monitoring and autoregulation-based blood pressure management. This is from a group from Yale looking at patients with acute stroke and LVO, and the percent of the time that the patients spent above the upper limit of autoregulation was associated with worse discharge modified Rankin and 90-day modified Rankin scale. And that worsening sort of functional status seemed to be driven primarily by the presence of perihematomal edema and symptomatic ICH. Again, being above that upper limit of autoregulation and causing trouble. There is an ongoing, or I should say, there is a study that recently finished, the COGITATE study on TBI, also using autoregulation-based blood pressure or CPP management instead of using near-infrared. Because it's TBI, most of them have some sort of invasive ICP monitor. They're using an ICP-based index of autoregulation. We don't know what the results are, but so far, and this is from the Cambridge group, looking at their data, historical data, patients that spent a significant amount of time above that threshold of 0.3 that I mentioned before actually had much worse outcomes and increased mortality. I work at the Cleveland Clinic, and if you know anything about the Cleveland Clinic, of course, it's a heart hospital with all of us here basically at their disposal to make their lives easier and make them happy. So we get a lot of LVADs and ECMO. And as you know, these devices can be associated with a lot of neurologic complications. They have a need for anticoagulation. But more importantly, there is loss of pulsatile flow. And it's always been theorized that this is The brain doesn't like this lack of pulsatility that actually wreaks havoc in different vascular beds. There was a study not long ago in patients with LVAD that they actually looked at the aorta, and they found that the aorta was quite rigid. There were significant changes in the histology of the blood vessel that it led to vascular stiffness. There was a lot of fibrosis and collagen deposits, etc. And they theorized that these vascular changes may actually be responsible for some of the complications that we see, not only in the brain, but in other vascular beds, as I mentioned, including the kidneys. So this is the graphic representation of autoregulation in the patient that we had on ECMO. This was during the COVID pandemic, somebody who was quite sick in ARDS. As you can see in red, you have left and right, is abnormal autoregulation. So basically, over 90% of the time, this particular patient had completely abnormal autoregulation while this patient was on ECMO. When the patient woke up, had a lot of, did well overall, but had a lot of cognitive issues. So eventually ECMO was discontinued. He went for an MRI, and lo and behold, this guy was in his 20s. We see a lot of microbleeds, so no history of familial amyloid angiopathy, completely intact neurologically before that. You see superficial desiderosis and what have you. Granted, he was anticoagulated. He was never above sort of supratherapeutic levels. He was therapeutic for the most part. And the theory, of course, we cannot prove it yet, and we are actually studying this here with our cardiology colleagues, is that the loss of pulsatility led to impaired autoregulation with probably hyperperfusion during ECMO, and that led to multiple microbleeds that you see there. So one of the studies that we have with our cardiology and cardiothoracic surgery colleagues is looking at patients in acute decompensated heart failure. We monitor them during multiple sessions before and after LVAD implantation, and we're trying to understand what that loss of pulsatility means for the brain. So hopefully we'll have more data on that. But it's not just for patients who live in the neuro ICU, if you will. There was this study looking at impaired regulation and delirium in medical and surgical ICU populations. So while our diseases, ICH and subarachnoid hemorrhages, are really not that common, for medical ICUs, sepsis, ARDS, and all the surgical ICUs, they tend to be a lot more prevalent than ours. And this could have a prominent impact. And that abnormal autoregulation was tightly correlated with delirium. And as I showed you before, they actually were able to calculate sort of optimal mean arterial pressure. And there are ongoing efforts to try this approach in patients in the medical ICU to see whether that leads to decreased delirium incidence. So that remains to be seen, but may have application, beyond just the four walls of our neuro ICU. And of course, I don't think any talk about multimodality monitoring, especially non-invasively, would be complete without talking about transcranial Doppler ultrasound. We have this robotic probe that holds it in place. The nice thing is that the robot, the machine, the AI, if you will, knows what a TCT waveform should look like. It searches for it automatically and then clamps it there and follows that as long as the patient doesn't move excessively. So that takes away some of the human error. And one of the studies that we're doing, and one of the things that we started doing here a few years ago was using we started with the Montreal protocol and intravenous milrinone, and then when nicardipine was not available for ventricular intrathecal use anymore, we switched to milrinone intrathecal. And the question has always been, what's the right dose? So we're doing a pharmacokinetic study to try to understand that a little bit better. But because we have this ability to monitor patients in many different ways, we're doing transcranial Doppler and looking at the percent change in mean flow velocities with TCD. So you can see by 2 hours, they have typically on average decreased about 40%, but by 6 hours, they're already back to baseline or close to it. But also PRX, or pressure reactivity index, another measure of autoregulation based on invasive ICP, is quite abnormal in this patient population. And with milrinone, though, we're actually able to correct it quite significantly. Once again, that red line indicates a 0.3 sort of magic threshold. By hours 4, 5, 6, we see abnormalities. And that abnormalities in autoregulation sort of correlates the increase in inflow velocities. We need one more patient to plug into our pharmacokinetic model, and hopefully we will have completed the study at that point. But so far, it looks quite promising based on what our preliminary results. All right. Now, non-invasive ICP is something that I've been interested for quite a period of time now. I truly believe that in my lifetime, we're going to be able to non-invasively determine very close, if not, quite accurately, what the actual intracranial pressure is. And I'll show you a couple of devices that one we have worked with extensively, and the other one we're about to engage with the company to work on it. So the first one is a mechanical extensometer. As you can see, it's a headband. It has this particular sensor. There is now a more modern looking version of this, but basically that sensor can detect micro expansions in the skull associated with each heartbeat. And as you know, the heartbeat is sort of the precursor, the engine for that ICP waveform. So it gives you a surrogate for what the ICP waveform looks like. They don't give you a number just yet, just the ICP waveform, and then you can do some sort of analysis with that. This is an actual snapshot that I took on the patient bedside monitor. The top white line is actual invasive ICP through a ventriculostomy that is closed, that is clamped. And the bottom, or P4 waveform that you see in white, is the one that we derived from the non-invasive ICP monitor. And I just wanted to highlight that, not for everyone, but for some patients, the similarities are actually quite remarkable. It's not just the similarities at the bedside. We have monitored a number of patients now. We did a spectral density waveform analysis, and we're actually able, whether it is invasive or non-invasive, to replicate or to capture the different frequencies, the waveforms that you would expect from cardiac, respiratory, the B waves that Lundberg described a long time ago. So all of those different waveforms that you would expect to capture and that you can capture with an invasive ICP waveform, you similarly can capture with this non-invasive device. I don't want to make things too complicated, but we decided to explore whether with this device we could actually use it to measure an index of autoregulation called pulse amplitude index. And basically what that index looks at is how much the amplitude of your ICP waveform changes in relation to changes in mean arterial pressure. Obviously, by definition, if increases in mean arterial pressure result in increases in the amplitude of your ICP waveform, your autoregulation and cerebrovascular reactivity are impaired. So we ended up with 24 patients that we retrospectively looked at that had undergone invasive and non-invasive ICP monitoring for a period of time, usually about 30 to 40 minutes, using our ICM Plus platform and RStudio software. We analyzed the data. So this is a table summarizing the clinical characteristics of the patients, also summarizing the sort of the outcomes, duration of monitoring, etc. I really don't want to belabor the point other than to say that these are typical neuro-ICU patients, most of them with ICH or subarachnoid hemorrhage. All of them had ventriculostomy. On your left, you have repeated measures, linear regression analysis, showing that there was actually quite good correlation between invasive and non-invasive PAX. More importantly, the Bland-Altman plots showed quite significant agreement between both technologies for the determination of pulse amplitude index. So we actually think this is a very good, reliable tool to determine autoregulation non-invasively based on an ICP waveform, which still remains the gold standard. Now, not to deviate too much from that, we are venturing out a little bit more and getting a little bit more greedy. Besides autoregulation, can we look at compliance? And there is a number of techniques that have been validated for the estimation of compliance, but we're trying to use this particular one using transcranial Doppler and non-invasive ICP. And so far, as you've seen these repeated measures, linear correlation again, the preliminary results, this is only 11 patients, a project that one of my residents is going to present at NCS. It seems to work and perform quite well. The device that I mentioned before does have a software platform that calculates a number of different things, including the P2-P1 ratio, which is thought to represent an estimation of compliance, as well as the time to peak. And this is the type of output that they provide. and they give you a minute average, so minute by minute average, and you need at least 50% of good waveforms for the platform to work. Another thing that we're looking at of these three different ways of estimating compliance, namely time to peak, P2, P1 ratio, and the combination of TCD and ICP waveform, which one has better agreement non-invasively with the invasive counterpart. So we're working on that now, and hopefully we'll have an answer for many of these patients that may not be candidates for invasive ICP. Let's say ischemic stroke patients with malignant MCA syndrome, acute liver failure patients. We seem to have quite a few of those here with cerebral edema. Really not feasible to go and drill a hole and put an ICP monitor, but perhaps we don't even need ICP. We can trend compliance over time and hopefully impact their management in a positive way that way. Nonetheless, the heading of this part of my talk was non-invasive ICP. So, you know, we heard about machine learning and AI, and that's exactly what we did. We teamed up with a computer scientist, and what you see there in blue is true or actual ICP or invasive ICP, and in orange you have your estimated ICP based on our non-invasive device and A-line. We're still underestimating it by a few points, anywhere from 2 to 4 points. So we're narrowing in. The model is not quite ready for prime time yet, but I think we're going to be able to get it pretty close, where you put this device and you're going to be able to get a very accurate estimation within a couple of points of what real ICP is. Now, I mentioned that also there was another company we're working on, and they want us to do a validation study on their particular device. It uses oximetry, but it's a little different from the one that we have now in terms of how it works. But this is the type of output you get from this device. You get a waveform that looks very much like an invasive ICP waveform, but actually this is all based on oximetry data that they obtain. So you can identify your three components of the ICP waveform, and temporally quite related to ventricular systole and to the ICP waveform obtained invasively. More importantly, though, they have some preliminary data looking at invasive versus non-invasive ICP that looks promising. So they want us to come and validate their device and to use some of that, leverage some of that machine learning sort of collaboration that we have to try to refine this product. The advantage of this over the mechanical extensometer, of course, is the fact that it's less prone to movement artifacts. So I think there is quite a bit of hope for that in the near future. So to conclude, I think probing the brain in multiple different ways and with different devices, particularly non-invasive ones, provides valuable insight into the pathological processes that are going on in patients with acute brain injury, and may actually help individualize the care as opposed to using these blanket sort of one-size-fits-all approaches. I would say, though, that the platforms are very clunky. You can tell that they have been designed by engineers for engineers. And I don't have an engineering background, so you can imagine how that went. We need to also do our part and try to do a little bit more training in bioinformatics and machine learning. I think all this is preliminary studies, very interesting, but I think we need to take it to the next level and identify the right trends and the right thresholds so that we can translate this into the clinical decision-making at the bedside. And honestly, I believe it's the next frontier in individualized neurocritical care management. And as I mentioned, not just neurocritical care, but I think critical care in general may have a role as well, even though it's very brain specific. I want to acknowledge some of my collaborators here at the Cleveland Clinic. Once again, Dr. Naval and the organizers, thank you so much for your kind invitation. I'm happy to take any questions.
Thank you, Joe. Any questions? Hey, Joe, one quick question for you. I rather comment on, so I can gauge your thoughts. When the Cambridge group initially came out with, the concept of optimal CPP and optimal ICP, they made the argument of how an ICP of 15 can be pathological in one patient and an ICP of 30 in another one can be totally fine and not hurt the patient. Unfortunately, with all the data that they accumulated, ultimately, the Brain Trauma Foundation said, okay, we're going to change our ICP goal based on that data to less than 22 instead of 20. it's a little disappointing when the goal, I guess, of the Cambridge group was to show that different peoples have different thresholds for optimal ICPs and CPPs, was for another organization to take the average and then say, hey, guess what? Let's move it a little bit 2 points higher. How do you think, like I know we're doing a lot of cool things, but do we really think that we can move to a point where therapy can be individualized based on some of the data that you're bringing up? I'm just disappointed by what happened with all the initial data that came out from Cambridge, where really different map codes based on whether it's ICH or subarachnoid hemorrhage or CPP goals. And it doesn't seem to matter. We have the same CPP goals for everyone, same ICP goals for everyone. How do you think, when we talk about the next frontier, how do you think we can actually achieve that from a practical standpoint?
Yeah, I mean, I think you make good points. I think you get a sense that I'm not a big believer in these one-size-fits-all approaches. Of course, that's what guidelines attempt to do. And I guess, if you take a population large enough and you give them some of these sort of ranges for blood pressure, overall you might benefit some patients, but I really don't think that's the best approach. What about somebody with a small ICH versus somebody with a very large ICH? What about somebody who lives in the 220s versus somebody who lives in the 160s, right? So that's why I philosophically cannot get behind this type of thing. And I know you're talking about TBI, but I think similar arguments can be made for ICH. TBI, they have Cogitate studied their effort. And I think they're going to push it to the next level, depending on the results of this phase 2 study, to see if they can do a phase 3 randomized clinical trial where they're going to be managed either by CPP goals alone or by this optimal CPP concept. In our experience, we have shown that you can feasibly calculate optimal map in these patients real time. We don't do it because the platform is not FDA approved, so we shouldn't use it for clinical care. And for all the regulators that are listening, we don't use it for clinical care. But the reality is that it's very easy to turn on that functionality and get that type of information. Now, I should mention that if you use the method described by the Cambridge group, you need about 4 hours of data to be able to come with one of those nice graphs that I described. There is a different method described by a group in Belgium using another index called LAX. I don't have a lot of experience with it because it's not open source, so they never publish their methodology. We're trying to reverse engineer it to see if we can achieve the same results that they did, but they claim that with that technique, you can get minute-to-minute optimal blood pressure or optimal CPP. If that's true, that would make things even easier and more feasible. The last comment I would say is that study that I showed you about LVO and autoregulation, that's from the Yale group. And my understanding is that they have secure NIH funding to actually enroll patients in the study after they undergo revascularization to actually sort of randomize them to autoregulation guided blood pressure management. So it's quite feasible, and I think that's sort of how we're going to get to the next frontier of individualized care.
Thank you, Joe. Very exciting.
Thank you, guys.
From a nerdologist standpoint.